30 participants. I'm not the most patient person, so we're gonna go ahead and start. So welcome to Grand Rounds today. So we will start our Grand Rounds with a land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So welcome today to Grand Rounds. We're excited to have Dr. Hilary with us this morning, who is no stranger to all of us at CHEO. So she is an assistant professor, only because she doesn't apply for promotion, because she should be a full professor. I'm just going to add that little comment, in the Division of Pediatric Critical Care in Department of Pediatrics. And she also is the Vice Chair of Education in the Department of Pediatrics at University of Ottawa. She completed her MD and her pediatrics training at Dalhousie University and her pediatric critical care training at the universities of Melbourne and Toronto. And she is going to speak to us today about leveraging the hidden curriculum for education and change. Welcome, Dr. Ritter.
Thanks, Donna. Good morning, everybody. We understand some people might be having some Zoom issues, so hopefully people will trickle in. Good to see everyone on Zoom. Yes, I'll come back to the assistant professor piece, Dr. Johnston, during my talk. I would like to acknowledge that unfortunately Dr. Doja Asif is not here with me today. He and I were going to give this talk together. Asif is actually the real expert on the hidden curriculum, not only in Ottawa, but seen as an expert across Canada and internationally. And he did a lot of the initial work that's been done here in Ottawa and has been involved in some of the curricular changes associated with the hidden curriculum. He's unfortunately not with us today, and I'd like to send condolences to him and all of his family. These are our disclosures. That in and of itself is my little introduction to the hidden curriculum. If you're wondering what on earth it is, that is an example of the slides that you will often see when you go to talks about people's disclosures. And you'll notice that I flipped the slide up for about half a second. You'll also notice that some of the disclosures are a bit of a joke. And it really reflects how we send messages about the importance of the conflicts of interest that we are asked to declare in any of our talks, and whether or not that really is valued or valuable at all. So these are my objectives for today. Hopefully we'll manage to get through them. They've been published ahead of time. We're going to talk a little bit about a definition of the hidden curriculum that is probably murky for many of you and murky actually for all of us, you'll see. We're going to use some examples from clinical work and from real life that will perhaps give you a little better context. And I'm going to offer you some strategies for how you can address the hidden curriculum. So we're going to start with a background and definition, and then talk about the examples, and then talk about some of the strategies. And hopefully we'll have some time at the end for some questions. So, what exactly is the hidden curriculum? For a lot of people, they go, my God, that's kind of hidden to me, and I'm really not sure what it is. I think all of us know what the formal curriculum is. You can go to the University of Ottawa Faculty of Medicine website, and you can see the curriculum that is designed for the Ottawa undergraduates with written goals and objectives. You can find the expectations in a book. You can know that you're going to write exams in various parts of your curriculum and get assessed for that reason. So I think we all understand what that is. But what exactly is the hidden curriculum? The term, as it applies to medicine, was originally coined by Frank Hafferty, who has written a lot of the literature related to this. And he describes it as both the informal curriculum and the hidden curriculum. So I'm going to focus today really on the hidden curriculum, and we'll talk a little bit more about that particular definition. But first, what is the informal curriculum? What does he mean by that? So that is an unscripted part of the curriculum, and it refers really to those kind of unplanned teaching moments that happen to us all the time. Someone sharing a pearl in terms of patient care when they're on clinical rounds, a hallway conversation, a piece of advice that you receive from your attending, from your peer, from your allied healthcare professional. There's nothing written about what that teaching is, but it is viewed as an essential counterpart to the curriculum and viewed as something that is positive teaching. There is some role modeling included in that informal curriculum, but I will come back a little bit more to role modeling as it is part of the hidden curriculum. So the hidden curriculum instead is a set of influences that are functioning at the level of organizational, by which I mean our hospitals and our universities, structure and culture, and a set of processes and pressures and constraints which fall outside the formal curriculum. You can't find objectives written down anywhere about this learning. It's largely unarticulated by us when we are teaching it, perhaps unrecognized by us when we are teaching it, and often unexplored. So is it that? Are the informal and hidden curricula actually interchangeable? So a scoping review done by Carlton Lawrence in 2018 looked at all of the literature that had been written on the hidden and the informal curriculum. And in that scoping review actually made the case that in many of those articles, the informal and the hidden curriculum were kind of used interchangeably, and recommended perhaps that we should discard the term hidden curriculum, discard the term informal curriculum, and think about, a completely different term, or even recognize that the hidden curriculum is no longer hidden because it is forming part of formal curricula now. And perhaps we need not to give it such a negative connotation. And so those of you that know Shakespeare will say that what's in a name is the first part of the famous soliloquy about a rose by any other name being so sweet from Romeo and Juliet. Of course, it's February and it's Valentine's Day next week, so I couldn't resist putting this reference in with a rose and some Shakespeare and a reminder of Romeo and Juliet and the tragic love story. And really, the reason for this picture is because Frank Hafferty actually was asked to comment on that scoping review, and he disagreed with their suggestion that we should abandon the term hidden curriculum, and said that, if we don't actually really recognize that this learning is hidden and unintentional, we're really not, in a way, paying attention to really important things that are shaping how physicians practice and behave. And so I think it's worth still using that term. So in fact, it's unintentional learning. And the way that Frank Hafferty coined it is what the university teaches without intending or being aware that it is being taught. And so you may or may not agree with Oscar Wilde from this Peanuts cartoon, who said that nothing that is worth knowing can be taught. But perhaps that in and of itself will allow you to think, do I think that the hidden curriculum is a good thing? Do I think that the hidden curriculum is a bad thing? And we'll explore that a little bit more. So I'll give you an example. You're probably wondering, I still don't really have a grasp on this. And you will get more examples through this talk that hopefully will allow you to think more carefully about this in your own practices. So a hypothetical, and I say hypothetical, but in fact, let's say real, Faculty of Medicine uses written exams to assess performance on most blocks, or written exams to assess performance with regard to medical expert competencies. And yet the block on professionalism and ethics doesn't have a written exam attached to it, and it's assessed merely through student attendance and participation. So what is the unintentional learning from that about the value of professionalism and ethics? And I will just ask you to reflect on that a little bit as I keep talking. So why are we talking here today about the hidden curriculum? Some of you have heard this talk before in various forms. The program directors had a faculty development about the hidden curriculum, and it's front of mind, particularly at the moment, because there's this small thing called postgraduate accreditation, this teensy-weensy thing that is an accreditation visit and an external review of all of our postgraduate programs at the University of Ottawa. And there actually are a set of standards that we need to adhere to. And one of those standards in the current version of the accreditation standards does ask that we evaluate the learning environment, including any influence, whether it be positive or negative, resulting from the presence of the hidden curriculum. The prior set of standards actually had an additional standard that asked teachers to reflect on the potential impacts of a hidden curriculum on the learning experience. I think that's disappeared from the standards because for many teachers, we really just don't really understand what it is. And so it's difficult to reflect on those impacts if you can't really yourself define the hidden curriculum. The Future of Medical Education in Canada vision was described in 2010 by the AFMC, the Association of Faculties of Medicine in Canada. And they included for curriculum reform in undergraduate medical education several domains. And you'll see there that one of the domains that they included was a need for us to teach and address more about the hidden curriculum. And so we really have a mandate at the university to bring this more to light. I spoke a little bit about the hidden curriculum and how it influences how physicians practice. And it's really important because it's theorized really to be related to and to have an effect on our development of our professional identity as physicians. And it's also theorized that the conflict, the tug of war that exists between the formal curriculum and the unintentional learning from the hidden curriculum has negative consequences on our identity formation as physicians. That is the theory. What are those consequences? Loss of idealism. And I'd like you to, maybe as you're listening, to reflect yourself and think about over the course of your career, over the course of your training, do you think that these things might have happened to you and wonder why? So, are you less idealistic? Have you developed a ritualized identity? Have you developed emotional neutralization? And do you wonder if your ethical integrity is different from when you started? There's a lot of evidence in the literature that this is happening. Most of the evidence is related to undergraduate medical education. This is a paper that Asif wrote with Chantal Clarkin, one of our education researchers and a medical student, who looked at online discussion forums that medical students can partake in. And they were able to do a qualitative analysis of a large number of posts on those forums. And they demonstrated that according to what your level was in medical school, the beginning of medical school, the end of medical school, as you were getting towards your residency applications, that there was much more cynicism in the posts. And the cynicism was related to various pressures, to working in resource-limited environments, to observing unprofessional behavior, to thinking about how one would manage all of the stresses that are attendant with a medical career. And so somewhere that is being learned by the experiences these students are having in medical school. What about the loss of idealism? This is well described in the literature and still in the recent literature. This study is from 2022, a longitudinal study observing some traits within medical students from, again, the beginning of medical school to the end of medical school. These investigators assessed student personality traits, some elements of that, and they also assessed some other attributes of students, including perfection and concern over mistakes, tolerance of ambiguity, resilience, and a calling to medicine. And they demonstrated over time in qualitative focus group interviews that perfection and concern over mistakes increased throughout medical school, whereas tolerance for ambiguity, resilience, and a calling to medicine decreased during that time. And we worry that these negative consequences to our professional identity formation and our physician behaviors may translate into negative changes in patient-centered care, and that perhaps patient-centered care falls by the wayside as we're changing. I'll come back to that. Are there any things about the hidden curriculum that could be good? And I'm going to introduce this topic, and again, when we speak about some of our real-life examples and some of the ways we can target the curriculum, I'll come back to this. This is an article by one of our previous University of Ottawa medical students, Robin Mackin. Again, qualitative focus groups using terms connected to the hidden curriculum. And the themes that came out, you can read at the bottom here. And you can see that there's a very small slice of the pie associated with positivity themes. Now, I would argue that if you look at the gray slice, which is a rather big piece of pie, that navigation and negotiation in terms of that element of our careers is also something positive. You know, it is a progression of our careers, and there's a lot of positive learning to be had from that. And you might also want to reflect about whether or not there's actually positive learning from things like vulnerability, privilege, hierarchy. Maybe not so much positive learning from dehumanizing experiences, but I'll come back to that too. So let's talk about real life and lived experiences. So Asif and various colleagues, including myself, did a cross-sectional qualitative study with some focus groups of various levels of training, including faculty members at the University of Ottawa. What was a little bit different in this particular study was that we actually did include faculty members in the focus groups. And we asked them to share their experiences in training. And we came out with a number of themes that were very common and really very prevalent across all of the focus groups. So we had medical students, residents, and faculty members. And these are the themes. There were 7 of them. And I'll go through them just to give you some examples from the real life and some examples from some of the quotes. And I'd like you to reflect yourself as you hear about each of these themes about where maybe you might have viewed some of these things in the clinical domain or in your work. So privileging. These are quotes that have been overheard at CARM's sessions and probably will continue to be overheard at CARM's information sessions for medical students. Change your personal letter for each program to include specific information about that city and why you want to go there. Always back up with family medicine. Is it okay to get a reference letter from a community physician? So think about even those topics in a special interest group for how to get into a particular specialty. Think about what that sends about medicine that is being practiced in particular cities. Think about the message about backup with family medicine and what that means for family medicine. Think about the teachings about the value of a community physician. If somebody doesn't know if a letter from a community physician is valuable for entry into a residency. Hierarchies. I'll come back to this also with some clinical examples. This is a quote from one of the focus groups. So with surgical staff, that hierarchy is well established and like revered. You know, this was speaking of surgeons, pride themselves on sort of abusing the junior residents. And I don't think it'll take us very long to just reflect and think about how hierarchies are alive and well in our current culture. Here are some examples. Case room nursing staff or any nursing staff are perceived by medical students and residents to treat residents differently from attending staff, to perhaps be less collaborative in terms of their work with medical students and residents. These are perceptions, but they are prevalent amongst the undergraduate community. An MRI or a particular investigation gets done more quickly if it's arranged between the attending staff rather than maybe between the residents, even though those residents might know that patient much better than the attending staff. And during debriefings of simulation events, nursing and allied health professionals, even though they are extremely valuable and absolutely necessary parts of the team, are rarely, or if not never, the first to speak during simulation debriefings. And all of that really reflects this hierarchy that we have of, the attending faculty is kind of the most important person. Unprofessional behaviors. How many times have you thought to yourself or heard yourself saying, oh, that's just so-and-so? Here's another quote from one of the focus groups. You learn through shock and trauma. So when you're yelled at, you never forget. And so these things, these little things here and there. For the most part, you don't tend to remember the people who are lax, but the people who are strict and give you about stuff. And you make sure that you do it their way, which is whatever, just make it easier. So think about the modeling that is happening here, right? The choice, possibly unconscious, to model the, in quotations, strict person. And the reason to do that, because it's just easier. And in these focus groups, definitely the all of the participants from undergraduate through to the faculty talked about experiences where they had observed unprofessional behavior and they just did not report it. They kind of brushed it off. Oh, that's just the way that it is. Emotional neutralization. This is from a medical student focus group, year 3s. In medical school, you're not really seeing patients that much, and you can learn about all these things, and you still are like, oh, that's so sad. All these people are dying from cancer. But I think when you're practicing, I think you just can't, or it's more difficult to continue functioning if you're always emotionally on. And if I reflect on the area in which I work, the intensive care unit, I almost need to have a degree of emotional neutralization because I can't continue to do my work if every time something stressful happens, every time a patient dies, unexpectedly or expectedly, I really need to, I decompensate. And so somehow that is possibly a protective mechanism to allow one to continue practicing in one's career, depending upon your career choice. What about cultural norms? So imagine this is a cardiologist teaching in a patient's room. So student A says tentatively, well, I might have heard S1, S2, there might have been a systolic murmur. The preceptor says, I don't want your opinion. I want you to report your findings. Did you hear the heart sounds or did you not? Student B steps in and in a confident tone and with confident body language reports, I heard a 2 out of 6 mid-systolic murmur at the left sternal border radiating to the pulmonic area. Preceptor lauds that particular student. Maybe that particular student didn't hear that, but had read the patient chart and knows that that is what is going on with the patient. This is about the culture that rewards a presentation with regard to your body language of confidence and matches sometimes confidence with competence. How many times have you heard people comment in evaluations or come and speak to you, if you are one of us who are involved in a lot of assessments, about a quiet student or a quiet resident? And think about how quiet often has negative undertones about competence. And there's really no evidence that that exists at all. But quiet definitely seems like it has a negative connotation. And these are our cultural norms. Transitions. So huge differences from stages of training. These would be some examples. A medical student, despite having 2 years of training and having spent some time with patients during those 2 years, still feels completely inadequate during their first clerkship rotation. It's really all of the additional things that are existent within the hospital, all of those processes, structures, cultures that they haven't really been equipped for. A junior resident has difficulty receiving mostly meets evaluations on their ITARs because that is the concept of being average, and they have difficulty with understanding that they are average within a set of supremely high-performing individuals. And new faculty didn't understand or didn't anticipate the challenges of an academic career, or they had no idea about practice management. They didn't understand that they were going to be managers of their own businesses. Role modeling is very prevalent in the literature, and in many of the literature is really defined as the most important piece of learning associated with the hidden curriculum. And as I mentioned, some of the informal curriculum also has to do with role modeling, but a lot of the role modeling is really about our body language, the words we use, our tone, etc. So here are some quotes from the focus group. I find that as a resident, you learn, you emulate, and you say, okay, this is like you find your idol. You find this is the kind of physician I want to be when I grow up, like a superhero, right? And another quote, in medical school, I had friends who knew they were going to be surgeons. They knew that being a good surgeon would come from having a specific character. You had to be firm. You wouldn't hesitate. You may be a little blunt. There was not too much torquing. Short phrases, straight answers. That's a good surgeon. That's part of the demeanor, the drive, or the character. So they would build that character even before they began learning the formal curriculum of surgery. So where did they learn that? I might debate. And in fact, there is evidence also in a paper that Asif and his colleagues wrote that there is a lot, of course, of role modeling that is learned through television and Grey's Anatomy and Scrubs and various of those TV shows. But perhaps these medical students were also somehow unconsciously aware that this is, in quotations to them, a surgeon's character and the way in which they behave. Let's talk about examples from the clinical domain. So we also looked at ward rounds on the pediatric clinical teaching units, so on our own wards. And one of our research assistants spent a couple of weeks observing what happened during ward rounds. And the hierarchies piece really came through very obviously. You'll see here, this is kind of a graphic of how people naturally aligned themselves physically during rounds. So you'll see that, first of all, the available mobile computers, the WOWs, were always with the staff in the R3, never with the medical students or with the junior residents, and that the staff in the R3 were always standing particularly close to one another. Sometimes the parent was close. Sometimes the parent was also a little bit more distant over towards the medical students, but always the medical students were further away from the staff and the senior residents. And so where have they learned to stand that way? And this was very consistent on a daily basis in terms of how rounds worked. Now, this was a few years ago. It was pre-electronic health record, pre-COVID. So maybe some of this has changed now, but it was interesting that the team organically seemed to develop a particular way of standing according to a particular hierarchy. And then with regard to the staff or the senior resident asking questions as a form of teaching, heaven forbid that the medical student would jump in to answer that question before the residents had had a chance to try and answer. And this has to do with hierarchies, but it also has to do, again, with our cultural norms. So think also about the fact that respiratory therapists, who know way more about mechanical ventilation than subspecialty residents do, only get asked questions during rounds about mechanical ventilation after the physicians have failed to answer. Think about how nursing staff may question medical students or residents, but rarely question attending staff decisions, when maybe those decisions need to be questioned too. Who else are we learning from? Asif and myself and various other investigators also looked at perceptions from medical students of the nurse as teacher in case room examples, so labor and delivery nurses. And the messages that came through were that nurses were important advocates for those patients, but also gatekeepers. And some medical students felt that, there was some obstruction to their learning with regard to the nurses feeling that they were gatekeepers for their patients. Now, you may want to ask yourself, we're talking about patient-centered care. So which part of that behavior is or is not patient-centered care? Just again, a reflection for you. We learn also from our patients. This is a Canadian medical study of medical students whereby 86% of them related or reported experiencing a form of mistreatment by patients within the confines of this study. But none of them had reported that experience to any body within their university or within their hospital. They also reported that because of the mistreatment, they had difficulty maintaining empathy. Remember, we talked about the emotional neutralization, and perhaps that is a defense mechanism, and difficulty maintaining engagement with those patients. Understandable. The reasons for not reporting these mistreatments were given as stoicism and an understanding that it's one's professional responsibility just to have those experiences. Faculty also struggle with aspects of the hidden curriculum. So this again is an article by the University of Ottawa folks, including Dr. Whiting, really looking at kind of a forum article about the hidden curriculum of the importance of clinical teaching excellence and the messages that are sent to staff about how clinical teaching excellence is valued, and also the lack of communication or clarity about what exactly that means. And Donna said, I didn't haven't been promoted because I refused to apply for promotion. And perhaps some of the reason that I haven't is related to this hidden curriculum. Oh yes, we value you very much as a clinical teacher, but actually the only thing that you have to do is publish papers. And there is work being done on that, but think about the message that that sends to clinician teachers. So, can we treat the hidden curriculum? Are there things that we can do? So after the initial article came out, that was the article about the focus groups that I was referring to, Dr. Doja made the National Post and made several other papers and had the opportunity to be interviewed by several media outlets. And this really kind of raised the profile of what needs to be done with regard to the hidden curriculum. It's not that there were not already initiatives in place, but I think some of the quotes that we were able to draw out from our focus groups kind of really gave people more impetus to think that we needed to work harder on addressing this. And so what can we do? I'm going to ask all of you who are listening here to make the hidden curriculum more explicit. And I'll talk a little bit about how you can do that. There are positive aspects of it. You can emphasize the positive learning that is associated. We're going to see if we can immunize folks against the hidden curriculum and think about how we can truly, truly promote patient-centered care. That word, patient-centered care, or that expression, is thrown around a lot. And sometimes I myself have to stop and reflect about the extent to which we are or are not really doing that. So let's bring it to light. Let's think of examples. Let's highlight them in all of the work that we do. So I'll give you an example. Just as I said earlier, I was required the last time that I was on service to speak to the anesthesiology folks, and I was required to speak to the radiology folks to organize an MRI. My resident knew a lot more about all of the reasons for that patient needing an MR, had a lot more detail about that patient's history, but it was me that needed to do that. I will often, from the perspective of the informal curriculum, I will say to my trainees, you should really be careful about the way in which you speak to referring centers on the phone when you get a transport call. Please try not to be disparaging and or impatient with them. They are working with resources that are different from ours, and they will probably feel uncomfortable with the amount of resources that you have. So first of all, that is a whole lot of unconscious bias that I'm sharing there. And second of all, I may say that, and then they may actually hear me while I'm talking. For a particular transport call, they may hear some impatience in my tone. They may see my body language change, and I may not even be conscious of that. So think about highlighting things like that. You can, if you stop to think, there are many, many hidden curricular learnings that happen all the time. If you even reflect on everything that I've spoken to you about today, I'm probably actually expressing the hidden curriculum in every slide. And if we just stop to think, we could think about many examples that we could highlight. Dr. Dhanani will often sit with our trainees at the end of every week and say, what have we learned from our patients? And I really love that. And I've stolen it from Sunny. And I think what happens from that is that we talk a lot about some of the medical expert things that we've learned from our patients, and maybe less about some of the other intrinsic competencies that we can learn from our patients. So perhaps we can think about highlighting some of those things. Let's emphasize the positive learnings that do come from the hidden curriculum. This was a qualitative study of clerkship experiences after an end-of-life care, so after a adult palliative care rotation. Again, with medical students participating in one-on-one interviews. And the students expressly stated that the fact that they were with a teacher and receiving some mentorship was far more valuable than any didactic teaching, that they appreciated the role modeling that was happening by virtue of their opportunity to observe attendings, that it helped them to understand the difference between cure and care and the synergy between cure and care. And they did view that the detachment of attendings, their emotional neutralization, was a necessary self-preservation. What did we learn from COVID, the pandemic that we are or are not still in? I can't quite figure it out. We learned how we could deliver optimal care in conditions that were very much suboptimal at the start. We learned about continuing to practice and teach in conditions that were suboptimal. We learned about being humble, saying that we didn't understand or didn't know everything. We learned about being vulnerable. We learned about admitting that we were tired, exhausted. It was too much. We learned about the importance again of altruism. We're reminded that this is hopefully a vocation, this profession. And we learned initially of our self-worth. Remember everybody sending us messages about the heroes in healthcare. This is a reflection article from October 2020, still in the midst of the COVID pandemic. Let's talk about our own area, pediatrics. So it is actually a myth, or at least has been proven through this qualitative study, that the attrition of empathy in pediatrics residents happens. So these were focus groups with R3s and R4s, residents at Sick Kids. And in fact, the R3s and the R4s, the themes that came out from those focus groups through qualitative examination were of increased empathy due to patient experiences, more learned patient experiences, and experiences with all team members. Those residents who had experienced adversity, be it personal adversity or personal adversity that happened at work, actually were protected against the loss of empathy. So a resilience feature was protective against that loss of empathy. And all of the residents strongly advocated for increased autonomy and responsibility with their patients and increased exposure to longitudinal relationships with their patients. So can we immunize folks against the hidden curriculum? You heard me speak earlier about the backup with family medicine. And there is a lot of unintended learning about devaluing and the lesser value of primary care careers. This article did a qualitative exploration of reflective diaries by medical students throughout their medical careers and demonstrated that when medical students start in first year, their sense of primary care career and its value disintegrates over time. Can we immunize against that? Yes, we can. This is an article from the University of Texas, who used an innovative curriculum called the SCOPE curriculum, Students' Continuity of Patient Experience curriculum, which was longitudinal interaction with patients from the beginning of medical school through to the end. And that resulted in a significant increase in them stating that they were going to choose primary care as a career choice. This similar curricula have been used in the United Kingdom with similar changes in choice and interest of primary careers. Can we really practice and be true to patient-centered care? Can we teach our students the importance of patient-centered care? The solution for this, and there are many of them described in the literature, are longitudinal integrated clerkships. The first one that was described was in Harvard in 2007. And I'll give you an example of what the Harvard one was, but it basically was the framework for all subsequent, and they all contain these elements. Close and continuous contact with patients, with the same patient. So the student follows their patients through major venues of care, maybe even goes with their patients for an imaging study, a procedure. The curriculum necessarily requires reflective exercises, and there is a particular emphasis on ethics, cultural competence, and communication skills. The students in the Harvard cohort, they demonstrated no difference in their exam or OSCE scores compared with the traditional cohort. They performed better on comprehensive clinical skills self-assessments. They expressed more satisfaction with that curriculum, and they felt better prepared to cope with all of the professional challenges of patient care. Being caring, sharing decision-making with patients, understanding the social context and that effect on patients. There is still work to do with longitudinal integrated clerkships. It's ironic that there is a hidden curriculum even with those. In that, think about how complicated that is to schedule. How can you schedule a student to continuously follow patients from various areas of medicine? You know, these students in Harvard followed patients from pediatrics, medicine, psychiatry, all along their medical school over that 4-year period. You know, the scheduling just gives me a headache just thinking about it. And then all of these clerkships include a lot of reflective exercises. Well, qualitative research of medical students and their perspectives on reflective practice is kind of negative, to be honest. There's a general antipathy towards reflective practice. There is a pushback against the sense that it demonstrates vulnerability in a milieu that rewards confidence and competition. And so we do need still to think about what these curricula look like. There are some that still are available and are working on some of these aspects. There's an interesting curricula called the review curricula that's written by Oli Tenkati, who coined the entrustable professional activities term, and his co-workers. And this tool is actually a tool of 50 questions that teams should ask about how they function. And it's intended to be a reflective tool for the whole team. So for instance, the team sits down and says, let's ask ourselves if our team always, so you're supposed to start the reflection with our team always looks after other team members when they've had a stressful day. And the team is intended to sit down and reflect about that. So you can imagine those reflections are probably super powerful, but do we have the time to do that? The 4-step curriculum that's identified below is from Glenn Regier and his colleagues. And this curriculum is actually intended to empower medical students and those on the lower end of the hierarchy to model professional behaviors, even when they view unprofessional behaviors. And so there are 4 steps of the curriculum that allow medical students to continue to demonstrate professional behaviors when perhaps there are unprofessional behaviors continuing around them. Have any of these curricula been evaluated yet? No. A recent scoping review of all of the curricula that mention addressing the hidden curriculum really only showed that the curricula exist, but that we haven't yet evaluated them. And speaking of curricula, the competence by design curricula that so many of our residency programs have transitioned to now was designed to be more patient-centered and more socially accountable. And I'd like you to reflect, honestly, to chat about the competence by design curricula and the hidden curriculum associated with the competence by design curricula, good and bad learnings, would probably take a whole entire Grand Rounds. I'd like you to reflect about how much do postgraduate learners learn about professionalism from getting EPAs signed? Think about next time you, if you're a faculty listening, think about the next time you do an EPA. Can you teach a little bit about the hidden curriculum? Think about, is the competence by design curriculum, is it truly more patient-centered? Is it truly more accountable to patients? I'm not going to give you any answers to those questions, but I'd just like you to reflect on that. What are we doing locally? What is happening at the University of Ottawa? Well, there is a large curriculum renewal that is basically in the middle, and it has begun with a competence-based curriculum that now exists in undergraduate medical education. And our medical students now have their own 12 entrustable professional activities that they need also to get completed. And the curriculum definitely includes now and has brought to light and has formalized some of the aspects of achieving a positive learning environment. There are written objectives about that and about the expectations. And there are surveys of the learning environment. There is some work being done on longitudinal integration, providing more longitudinal opportunities with patients. There's a lot of work being done on implicit bias, unconscious bias. And I think there's a lot more transparency in our curriculum about the things we struggle with: physician burnout, fatigue, stresses, the difficulty of maintaining empathy. So we have brought some of this hidden curriculum to light and greater awareness. We are continuing to do faculty development and workshops that, further clarify the hidden curriculum across really all areas, not just faculty, but also undergrad and postgrad. A recent thematic analysis and a scoping review demonstrated that very definitely the curricula is aimed so far towards the undergraduate area. And a lot of the literature that's been published has been related to medical students. And really, we need to continue to work on the approach for attending faculty and the approach for our organizations in which we work, our universities, our hospitals. There is a lot of hidden curriculum learning that comes from just working in those areas. And so there's a lot more work to be done from that perspective. So final reflections. I'd ask you to reference this little reflective article written by a GP in Britain. And this came out after some of the original articles about the hidden curriculum. He said, I'm going to write my own hidden curriculum, and it's going to contain the following. It's going to be what my patients teach me. I'm going to go into my patients and I'm going to say, what do you hear when I tell you that you're non-compliant? Tell me the best way that somebody's explained your condition to you. tell me how well I did. What can I do better? What did I do that you'd rather I change? And at the end of every week, I'm going to reflect on some of those things. I'd like to see a hidden curriculum and hidden solutions. Many of our case-based learning and many of the learnings that we use in our formal curricula have defined solutions. We find a diagnosis for patients. We always get the answer. What about those patients that we don't know what's wrong with them? We never can coin their disease. Maybe we don't do anything and their disease just gets better. Perhaps we should include more of those in our curriculum. And let's think about showing us as humans the things that we really don't see. How do we look after our colleagues after we've had a bad day? Let's show ourselves having a difficult time. Let's be vulnerable. Let's admit that we don't know something. And when we don't know something, do we go to the literature, or do we do Dr. Google, or do we look at things in the Globe and Mail? Those sorts of things. And I really like that, that reflection seemed very much kind of aligned with the positive aspects of the learnings from the hidden curriculum. Okay, now I'm going to tell you guys the next slide is a video, and I am a total Luddite. I'd rather run a cardiac arrest than try to show a video when I'm on Zoom, but I'm going to try. That's my last slide but one, so let's see if it works. And the video is, I'd just like us to listen to it and reflect a little bit about what people are learning from social media, and also a little bit about the job in which we work. See if I can play it. It's not going to play. Doesn't play. Thought it would work. You guys can look at Dr. Glaucomflecken and look at Pediatrics is Easy if you want to see the video that I was going to play. So this is the last slide. And as I end and before I take questions, I would just like to acknowledge that it's Resident Appreciation Week. This hospital could absolutely not function without all of you. And you are invaluable. And I appreciate every day your hard work, your dedication, your professionalism, and your enthusiasm. And so happy Resident Appreciation Week from a bunch of people who were residents a very long time ago. And I will take questions.
Thank you so much, Hilary, for that excellent talk. Okay, there's one question in the chat. I don't know if it's a question or a comment from Stuart. When it comes to CBD, there's a hidden curriculum at play when the residents ask for an EPA and we tell them we'll do it later or don't do it at all. Or a curriculum that's not hidden if someone tells them outright that EPAs are useless.
Yeah, very good comment, Stuart. As I said, I could do a whole entire gram rounds on the hidden curriculum associated with the transition to the competence by design curriculum.
All right, Josh Shafton has his hand up.
Yeah, thanks, Hilary. This is fantastic and so important to think about. One of the things, I mean, as all of us get older, we see that we try to make these changes and some stick, but some don't. And it feels like one of the barriers is that the senior attendings who need to be changing the way that they approach things are really just falling back on what they learned, right? So the cycle continues. How do we change that? For example, just a very brief example, externally, what's valued is test scores and like maintenance of certification, right? And the Royal College is not asking me how my patients feel about me or what I'm reflecting on. They're asking me whether I read a paper or paid their money to take their test. And so I'm just wondering on your thoughts of how can we try to break this cycle of people saying, well, I went through hell, but I'm okay. Yeah. And so we can just continue it when, no, you're not okay. And it's not okay for the next generation.
Yeah, that's a really good question, Josh. I mean, I think it's going to take generations and not just a generation. And, I think that I do think that the changes in the undergraduate curriculum that really are trying somehow to address this are going ultimately to result in a generation of physicians, you know, who are different from us old guys who had these influences exerted upon us to a much more hidden degree, right? So it is now becoming much less hidden. You know, I would say from you yourself, that's why I say, really, if you yourself can even recognize during your clinical work when the hidden curriculum is at play and share that with your learners to say, you know what, guys, I just demonstrated an example of the hidden curriculum. That is the hidden curriculum. I think that if we hear and we see it in our daily life, will ultimately grow a generation for whom I think the hidden curriculum will still exist, but it will have much more positive aspects to it. Is there more work that's needed to be done with faculty development? Is there much more work that is needed to be done with our patients assessing us? Yes, absolutely. And, you know, that's why I say there's top-down work. That's the hidden curriculum again, guys. That's the hierarchies. There's top-down work that needs to be done by our governing bodies about our professional identity.
There's one in the chat, and then we'll go to Mark. So the chat question, Hilary, is what's the role of expressing gratitude in solutions?
Expressing gratitude in solutions. You mean, what's the role of expressing gratitude in a solution for the hidden curriculum? I'm going to presume that's what that means.
Yeah, sorry. So this is Robert. Yeah, that wasn't so clear, was it? Wonderful talk. Yeah, I was just sort of wondering your thoughts on. Maybe I missed that, but I'm just curious if you what your thoughts are on the role of expressing gratitude in terms of finding solutions to this hidden agenda. Like, like something we don't hear that, we don't see that or hear that done very often, but I know there's a lot of work in other fields on the power of expressing gratitude. And that goes for our team, to our patients, to the hospital, wherever you work. I mean, to the system that allows us to have this privilege to do the job that we do, right? I mean, it's really, we have an incredible privilege to be, listening to such intimacy and to be able to do the things that we do with total strangers every day.
Yeah, there's not a lot written specifically about that with regard to the hidden curriculum, but I completely agree with you, Roger, that, that's really about that patient-centered issue, right? Really being thankful that that patient has lent you kind of an experience of their life that oftentimes is, really difficult and challenging. And again, to kind of be more explicit about that, I definitely think would arm us against some of the negative aspects of the hidden curriculum, and not only to our patients, but to all of the team with whom we work. I think that as long as it's expressed, I think authentically, right, and truly meant, that it definitely would be valuable.
Yeah, you mentioned the word humility, and I wonder if those two maybe should go together, right? I mean, humility and, right, because that sense of being humble and knowing that you don't know everything, and you can't always figure out everything, you can't always help everyone, but you're at least, lending your attention and your expertise and your empathy really to what you're hearing and experiencing.
Yeah.
Thank you.
All right. Thank you. And the last question to Dr. Zucker.
Dr. Zucker, who also was one of the investigators on our clinical observations in our pediatric CTU. Hi, Mark.
Hi. Thank you. Such an important topic, and there's a lot of talk in your talk about sort of the undergrad curriculum and teaching our students and the impact on the students. And it's interesting, someone who spends a lot of time with the students, we put a lot of work into exposing the hidden curriculum, as you say, make it transparent, teaching them about it. But every time I talk to students after they've come into clinical venues, they say, I see the exact opposite to what you're teaching me, and in your comment about top down, I think we really now need to move to a top down process, where things like the culture of how we interact with each other, the way in which we do business, how we talk to one another, you know, and students getting off a phone and saying, I just got yelled at for calling a consult, right? And because I didn't have all the details at my fingertips. And things like that, where they say, you know, you teach me about respect and collegiality, but you know, and I just had a town hall with students this week, and majority of it is, if you really delved into it, it's all about the hidden curriculum they're experiencing in clerkship that is counter to everything we taught them. And
Yeah.
so I guess I put that challenge out to all of us to say, how do we really take this to heart? How do we improve the culture of what we're doing, and thinking about how we interact with our trainees, and really the role modeling and all these things that they see that uh, really tells them that some of these topics aren't as important as we say they are.
Yeah.
And it's so important. And as you say, yes, the new learners coming in are going to be an evolution to this, but we at the top need to start change.
Yeah, I agree, Mark. There's a lot of work to be done from, you know, I think really our governing and our organizing and learning bodies. But just so you know, Mark, I don't know if you're familiar with that Glenn Regeer article about the 4-step curriculum. That curriculum is actually specifically designed to empower medical students to actually kind of move beyond those unprofessional behaviors that they're seeing. I can share the reference with you if you like. Again, it hasn't been evaluated, but it sounds good. So I don't know if you're familiar with it, but I'm happy to share it with you if you want.
Well, thank you again, Dr. Ritter. That was an amazing talk, and really gave us a lot to work on and think about, and I think will make us all better physicians, clinicians, teachers, etc. So thank you again.
Let's hope so. Thanks, guys.